Good evening, and thank you for joining us for this virtual community lecture focused on brain tumors. I'm Treasure Joyce, manager of the Neuroscience and Stroke program at Providence Little Company of Mary Medical Center in Torrance. We are joined by neuro experts, Dr. Naveed Wagle and Dr. Walavan Sivakumar. Before we get started, I wanted to let everyone know that this is an hour-long presentation and we will have plenty of time for questions at the end of the presentation. Please use the Q&A box to type any questions you have throughout the event, and we will do our best to get to each question at the end of the presentations. We will not be opening it up for attendees to speak on this webinar. Before I introduce our first speaker for the evening, I wanted to share a little bit about the comprehensive neuroscience program that we have at Providence Little Company of Mary Medical Center in Torrance, and our important partnership with the Providence Neuroscience Institute, PNI. We are a robust comprehensive stroke program, and we see complex neuroscience patients. We specialize in complex stroke procedures, aneurysms, brain tumors, and also movement disorders. We are very blessed to have our partnership with PNI. And it's been so important to be able to provide that, all of these specialties to the community so that you don't have to go outside of the South Bay to seek these kind of assistance with these diseases. Lastly, I want all our attendees to know that the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions. Now it is my pleasure to introduce Dr. Walavan Sivakumar. Walavan Sivakumar, MD, is a board certified and fellowship trained neurosurgeon with a focus on skull-based and minimally invasive and endoscopic neurosurgery. A multiple super doctor award recipient, Dr. Sivakumar has a particular interest and expertise in brain tumors, skull-based tumors, pituitary and paracellular tumors, and intraventricular brain tumors. He also applies the keyhole concept, utilizing advanced imaging and microsurgical techniques to minimize collateral damage to the brain. In addition, he treats patients at the Spine Institute at Little Company of Mary to help relieve and cure back conditions due to spine involvement. Dr. Sivakumar is available for consultations for brain, skull-based pituitary tumors, aneurysms, and cavernous malformations, arterial malformations, carotid stenosis, and spine issues. He sees patients at both Providence Little Company of Mary Medical Center Torrance and Providence St. John's in Santa Monica. Dr. Sivakumar has over 40 peer-reviewed publications, and in addition to giving several podium talks at meetings on local and national level, he has received numerous awards for his research in cranial surgery and tumor biology. Thank you, Dr. Sivakumar, for joining us and for lecturing.
Thanks, Treasure. I'm very excited to be here, and I always enjoy how unpleasant listening to my own bio is. So thank you for that. As I mentioned, Dr. Wagle and I are really, really excited to have the opportunity to speak with the community today on what makes up the major part of our career and my primary interest. I'm going to try to keep everything limited to about 20 minutes, but I am very capable of talking on this topic essentially forever. A big concept that I want to show here is that brain tumor care truly and genuinely takes a village. This is a small number of our team at the Pacific Neuroscience Institute, where we have the capacity to provide comprehensive brain tumor care. I have no relevant disclosures. I am a consultant for Stryker and provide some education honoraria. So when we're talking about understanding brain tumors, we're going to go over the difference between primary and secondary brain tumors, a list of the common brain tumors and some of their incidence rates, some basic brain anatomy to get a sense of what's going on, some ideas and discussions about management strategy, an introduction to keyhole brain surgery, enhanced recovery after surgery protocols. So what do I mean by primary versus secondary brain tumors? Primary brain tumors are those originating from nerve and support cells within the brain. They come from the neurons themselves or the glial cells, or the surrounding covering cells that go around the brain. When we're talking about primary brain tumors, even though brain tumors as a whole make up a relatively small amount of tumors and cancer around the body, it's very complex and very variable. There's actually 126 different types of brain tumors listed by the WHO, and I actually think that's outdated data. An updated WHO classification that Dr. Wagle will be talking about actually lists even more than that. When we're talking about secondary tumors, the way most people think about them are tumors that arise from somewhere else in the brain and then spread to the brain. Typically, when we're talking about the brain metastatic tumors that come, they are usually breast cancer, lung cancer, kidney cancer, GI cancers, and melanoma. And actually, the number of those, as cancer treatments improve, the number of patients coming in and presenting to us with metastatic cancer to the brain are increasing because they're living longer. The longer you live, the longer you have a chance to have these tumors come to the brain. This is sort of a framework to show us what we're talking about here. When we talk about all primary brain tumors, they're actually outnumbered about 3 to 4 to 1 compared to secondary brain tumors coming from elsewhere in the brain, which make up about 250,000 tumors that come a year. When we're talking about the common primary brain tumors, the 4 that we talk about the most are meningiomas, which are support cells that come from the arachnoid cap cells in the brain, gliomas, which come from the support structures. Dr. Wagle will be talking about this more. Those are the 2 most common. And gliomas, as you all have probably heard of, the most common of the gliomas are glioblastomas. And these 2 entities make up about 45 to 50,000 cases a year. My favorite tumors, pituitary adenomas, make up about 11,000 and are the 3rd most common primary brain tumor. Schwannomas, or neuromas, as they're more commonly called, when they're talking about inside the brain, is 4th with about 6,000 tumors. Out of the rest of them, they combine to make up about 8,000 additional tumor cases per year. When we talk about the etiology and what's the actual cause for these tumors, it's honestly largely unknown. There's some tumors that are historically associated with radiation. And when I talk about radiation, historically in the past, we used to give a lot higher doses of radiation. And for example, children used to get whole body radiation for certain cancers. What we noticed was patients with large dose radiation to the brain have been known to have higher incidences of tumors. Links have been postulated related to head trauma, petroleum, aspartame, and the most controversial of them are cell phones. In my opinion, the data related to cell phones causing brain tumors hasn't been convincing. There may be something that comes down the road, but nothing to date has been there. And I wouldn't make any recommendations against using cell phones at this point. Additionally, when we're talking about symptoms related to brain tumors, it's really more dependent on where the tumor occurs versus the size. You can see patients presenting very symptomatically with a centimeter tumor, and patients moving around in a different location of the brain with tumors 3, 4, maybe 5 centimeters and not even knowing they have tumors. So it's a very heterogeneous type of pathology, because the brain itself is not a homogeneous structure. When you think about something like the lung, for example, you can have a tumor taking up about half of the lung itself, and you can actually resect half of the lung without any sort of detriment or decrease in the function, because the rest of the brain, of the lung, for example, the healthy portions of the lung are oftentimes able to make up for or compensate for this lost structure. The brain, unfortunately, doesn't allow for that type of plasticity and homogeneity that would allow one part of the brain to take over the function of the other part that's lost related to a brain tumor. It could rarely assume this function of the damaged region. And until we get the brain transplant, we're really not going to be able to make up for that. So that makes the rest of our talk and the rest of the decision making critically important. A little bit of brain anatomy, because I think it's important to review this in any of these community type lectures. Here's a lateral surface projection of the brain. This is the frontal lobe that's largely associated with cognitive functions, voluntary movement. Here's the parietal lobe in this general vicinity right here. It's associated with processing information related to temperature, sensation, position, body position, and movement. The occipital lobe sits at the back part of the brain, and that's associated with processing vision. The temporal lobe is associated with hearing and memory, and the brain stem is associated with more involuntary movement or involuntary functions such as wakefulness and alertness. When we're talking about brain tumor care, it truly takes a village. Because the symptom presentation varies, brain tumor care is heavily reliant on multidisciplinary input. And the diagnosis of a brain tumor can only be made by pathological evaluation. And Dr. Wagle is going to be talking about some really exciting work that's being done that won't rely very invasive types of processes needed to acquire pathology. But right now, to date, you need tissue, you need blood, you need spinal fluid, or you need actual tissue itself. Another thing that complicates matters is once you have that tissue in the pathology, sometimes the interpretation of this tissue or this specimen is variable. So one person can say something, or another provider, another pathologist can say something else. And tumors, whether they're high grade or low grade, can have very mixed tissue within it, which makes interpretation even that much more complicated. What we use, which is the real metric that we use currently throughout the world in terms of classifying this data, is the World Health Organization classification of tumors. And because of the complexity of brain tumors, that tends to get updated very frequently. Here's what I mean when it comes to it takes a village. We have the patient at the center, surrounded by their support system, the family and loved ones, but there's so many different providers that are required to give the best type of care for these patients. And luckily, at the Pacific Neuroscience Institute, and extending that out to our partnership with Providence, we've been blessed, as Treasurer mentioned, to have the ability and the resources and the connections to really provide the full gamut of care required to take care of a patient with brain tumors. This is really honestly a simplified slide. Some credit to Robin Banuelos, my administrative coordinator, who made this slide. We really tried our best to simplify it, but there's so much here that's needed, and so many partners in this mission that we have. The role of surgery, and that's what I'm going to focus my time talking about. The role often is to acquire tissue for this histopathological evaluation. And you may know of that concept as a biopsy. So I can either go into the brain to acquire tissue for a brain biopsy, or when patients present symptomatically related to growth of the tumor growing in a certain location and causing mass effect, I'm often called upon to remove that tumor, to alleviate that mass effect, take the pressure off the brain in order to return to normal function or remove symptom improvement. So when we're talking about resection, this is a very busy slide, but the concept I want you to get, and this is where all of my training and all of the sleepless nights and most of where my stress comes from. When we're talking about surgery, it's a balance of striving for maximal resection while avoiding neurologic deterioration, because as I mentioned earlier, the brain itself doesn't have the plasticity that other organs have. One part of the brain can't take over the role of another part. And so we rely heavily on technological adjuncts that help us remove more tumor, because what we've seen and what all of the studies have shown is that increased extent of resection results in improved neurologic and morbidity and mortality outcomes after surgery. However, if neurologic deficits are created from surgery, a lot of the benefits that you see from the extent of resection, meaning removing 50% is better than removing 10% of the tumor. Our gold standard in glioma surgery, for example, is trying to achieve a 95% extent of resection without creating a new neurological deficit. What they've shown here in these studies is that if you achieve that 95% tumor extent of resection without a neurological deficit, you'll significantly improve outcomes. However, if you get 95% but develop a new neurologic outcome, it's like you never achieved that 95% resection at all. So taking that to brain metastases, so what we see the majority of in our practice, historically, what has been told is that patients, when you have a brain met or a brain metastasis, tumor from somewhere else going to the brain, really there weren't many options. Thankfully, that is not the case. And I want to try to show that. And Dr. Wagle is going to take it home with putting that message through. In 1990, a large center study showed that surgery followed by whole body radiation had the ability to significantly improve outcomes in brain tumor patients. This has continued to evolve because this is a wholly iterative process. And more recently, and where my special training and really career purpose comes in, is minimally invasive surgery with the combination of radiosurgery can be used to treat multiple metastatic lesions, meaning multiple lesions to the brain. And as Dr. Wagle's complement in our armamentarium has grown, this has come to include very exciting adjunct therapies, including targeted therapies and immunotherapy for the treatment for this disease after surgical resection or radiation. So when it comes to surgery, how do we make these treatments safer, achieve that higher extent of resection, and minimize the chance of developing new neurologic deficit? For us, at the Pacific Neuroscience Institute, some of these principles are brain tumor surgery is really only the beginning of treatment. Our aim is to attain maximal safe resection to restore function and quality of life while avoiding new neurologic deficits. We want to obtain sufficient tissue for biomarkers and targeted therapies that Dr. Wagle is going to talk about here. And we want to use a surgical approach that promotes early mobilization and shortens a hospital stay. That way, patients go into these adjuvant treatments, chemotherapy, immunotherapy, radiation therapy, and additional things, stronger and better able to handle them. So how do we accomplish that? My special training is in this specific concept, the keyhole. Keyhole brain surgery is a concept that centers around the idea of accessing the brain via smaller, more precise openings to minimize brain, scalp, and muscle manipulation. And that's often aided by the use of endoscopy. What we mean by that is aiming to achieve less bone removal, less soft tissue disruption, less brain retraction. When you injure the brain less, it preserves the normal physiology more. When that happens, there's less collateral damage, a more rapid recovery, and a shorter hospital stay. How do we do that? We go through a variety of different methods. These are some of them. We can access tumors through the nose, through endonasal transsphenoidal surgery that we do in conjunction with our ear, nose, and throat partners. Supraorbital, we can make tiny incision inside the eyebrow to hide the incision, and we can get to deep regions inside the brain. Additionally, we use cameras, gravity-assisted approaches, high definition, and special micro instruments to reach these areas while avoiding injury to normal brain. To do that, we rely on a lot of technology. We rely on high resolution tractography and high yield MRI imaging, which allows us to use brain navigation which allows us to know precisely where we are in the brain at all times. We use high definition endoscopy, like I talked about, to really bring us to the heart of the matter. We use blood vessel localizing probes called the Doppler, advanced potential neuromonitoring and cortical mapping. Right now, we have the technology to use tumor painting dyes that actually help us light up the tumor while leaving the normal brain tissue on or the normal color, so we can distinguish where the normal tumor is and where the actual tumor is and where the normal brain begins, as well as special instruments that allow us to get deeper in the brain to allow us to manipulate and mobilize the brain more. I don't want to go too much into the videos in case some people are squeamish, but this is a deep brain tumor inside of an elderly gentleman that required us to use this keyhole technique. What I want to highlight here is you're able to see this tumor painting dye highlighting the area of the tumor and showing the normal brain. So I can focus my instruments going very deep in the brain. We're talking about almost 8 inches here into the brain and really leaving the normal brain alone. And this high definition imaging and instruments can get us into the brain and leaving the normal brain alone. This is another one that I don't want to spend too much time on. We can show it near the end, but very large brain tumors can be approached through the similar smaller openings. And we can use those tumor painting dyes, and large tumors can be taken out through very small openings. And this shows the hole where the tumor used to be. This patient actually did quite well, avoided having a stroke and went home shortly thereafter. This is that eyebrow incision. So this looks like it could be a little bit concerning to patients from a cosmesis perspective, but we can get large portions of the tumors done through very, very small openings. And this is how our beautiful patient looked 2 weeks after surgery. You really can't even tell where the surgery was done. We've actually published on this. And this is another example of deep regions of the brain that we can get into. And we've actually published on the cosmesis using the supraorbital eyebrow craniotomy approach, where in the majority of patients, you really can't tell which side surgery was taken on. And when you're doing these smaller openings, patients get better faster, get out of the hospital sooner, are stronger after surgery, and that makes them stronger and more able to handle the next step in their process. One of these processes that I've taken a deep research interest in the last couple of years is this idea of enhanced recovery after surgery. How do we get patients to deal with the stress response related to surgery better and faster? And there's this concept of enhanced recovery, which was developed in other surgeries and actually in Western Europe about 20 years ago. And it involves healthcare providers in a longitudinal fashion, all working together to reduce the stress response related to the hospitalization. And they've seen tremendous decreases in reductions of length of stay, complication rates, readmissions, and reduced costs related to healthcare. I believe that the adoption of minimally invasive surgery is a key component of enhanced recovery success, and it represents a paradigm shift in the surgical repair of patients. Over the last couple of years, we've built out and published on our enhanced recovery after surgery protocol for neurosurgery. There's no established craniotomy or brain surgery enhanced recovery protocols, and this is one of the first ones out there. And we've seen a tremendous decrease in the length of stay. To give you a little context, historically, patients who undergo brain tumor surgery are in the hospital for about 4 days, with about a quarter of patients being in the hospital for longer than 7 days. The majority of my brain tumor patients who are accessed through a keyhole approach go home post-operative day 1. And it's not just to get them home, it's, as we talked about from that support system slide, patients, when they're doing well, they've had their problems reduced, recover better in their natural setting, with their family, in their bed, with their pets, getting up and moving around in their own setting. And all of these different aspects that we've incorporated, all of those different care providers are aimed at doing that. There's a lot more to talk about, and surgery is really only the tip of the iceberg here. But so in conclusion, brain tumors represent a complex pathology. Surgery now represents only a part of the management for brain tumors. Keyhole brain surgery, that's near and dear to my heart, is a safe and effective alternative to traditional cranial approaches. And technological advancements have resulted in improved outcomes in cranial surgery. Enhanced recovery after surgery represents a paradigm shift in the care of these surgical patients. And brain tumor care truly represents a comprehensive team effort with the patient at the center of it. I want to thank you for the time to speak today. We'll be answering questions at the end. Here's my information on the various social media apparatuses, so feel free to reach out with any other questions. Treasurer, I will return the floor to you. Thank you.
Thank you so much, Dr. Sivakumar. I'm completely impressed. I mean, I know a little bit about what you do, but sometimes you just astonish me. So what a great lecture and what a beautiful presentation. And you just inspired me more to help us move forward and impress upon that ERAS program. Thank you again for that wonderful presentation. Now I'd like to introduce Dr. Wagle. Dr. Naveed Wagle is a board-certified neurologist and neuro-oncologist. He serves as the Director of Clinical Neuro-Oncology Research and Associate Professor at Neurology at St. John's Cancer Institute. Dr. Wagle specializes in the diagnosis and treatment of primary and secondary brain tumors, including glioblastoma, multiforme, meningioma, brain metastases, as well as neurological complications of cancer. In addition, he is involved in the development and implementation of the innovative clinical trials. Dedicated to advancing medicine, Dr. Wagle conducts leading-edge research in the diagnosis, treatment, and prevention of all types of CNS tumors. He has developed therapeutic trials for metastatic brain cancer and spinal tumors, primary malignant brain and spinal cord tumors, primary benign or low-grade brain or spine tumors, and skull base and pituitary tumors. His research interests include development of molecular markers pertaining to the treatment and survival. And Dr. Wagle is a diplomat of the American Board of Psychiatry and Neurology and United Council of Neurological Specialties. These are all such big words. He is an active member of the Society of Neuro-Oncology, the American Society of Clinical Oncology, and the American Academy of Neurology and American Medical Association. Take it away, Dr. Wagle.
Thank you very much, Treasurer. Appreciate that introduction. And thank you for everyone for making time today to join us. Hopefully we'll get you some new knowledge and understanding of brain tumors. Tremendous presentation by Dr. Sivakumar already about the surgical aspects and kind of where we began and where we are in brain tumor understanding at this point. I'm going to talk a bit about clinical trials, because that's one of my research interests, the barriers to clinical trials and the treatment of brain tumors, and then a bit about molecular profiling, and we'll go into what that is. Clinical trials will be the first part of this, though. So we want to advance the fight against cancer. The way that we're going to advance that fight is coming up with new innovative therapies that work against these cancers, both to understand how to fight them, where to fight them, and in what method to fight them. And so a clinical trial at the very basic is an experimental therapy that helps us fight cancer as in this setting. We're all a little bit more familiar with clinical trials now, having or continue to go through COVID, because we've seen how some of those vaccines have come out and the studies that led to them. But in cancer therapy, it's a slightly different paradigm, and they're structured in phase 1, phase 2, and phase 3 studies. And that kind of leads from one to the development of these clinical trials. So need these clinical trials because obviously cancer is not something that we have cures for in the most part. And so if we're going to get to a cure, we need to find out how to best get there and what therapies are going to work. And then we want to get patients access to those clinical trials so they can beat their cancers as well. Now, how do you get into a clinical trial? Obviously, the clinical trial typically is very specific to a type of cancer. Most of our clinical trials at the Pacific Neuroscience Institute are for brain tumors, either primary brain tumors, which are things that start in the brain, or secondary, as Dr. Sivakumar explained, things that start elsewhere in the body and then spread into the brain or extend into the brain. And so these clinical trials have inclusion and exclusion criteria. Something that includes you is that you have to have a specific cancer. Something that excludes you is it can't be something different. It can't be another problem that's going on that's causing the symptoms that you have. And then obviously, if the question is, should you be in a clinical trial? And a clinical trial is experimental. So we can't say that it definitely will work for you or for anyone. But in many types of brain tumors, we don't have a therapy that clearly cures this. And so sometimes there's no better available therapy. And that's why we want to focus on these clinical trials. So let's start at the basics with what types of clinical trials are there. Prevention studies are kind of the big studies that try to prevent a disease from happening. These are usually very large studies and usually require populations to develop. We are doing some information on databasing and trying to figure out what causes cancers. That will hopefully lead to prevention studies. And there's screening trials. Screening means how do we diagnose and determine if there is a cancer in someone. Diagnostic studies are, or treatment studies as well, are to make a proper diagnosis, molecular diagnosis, meaning a genetic diagnosis, or a pathology diagnosis. And then treatment is really the crux of things that this audience probably cares about. What therapy is going to work for you? And then beyond that, there's also quality of life trials. Obviously, quality of life is an essential part of what we're doing. Fighting cancer is not just about beating the cancer, it's about giving you your life. And so we want to make sure that the therapies aren't too toxic, that they take away your quality of life if you have to go through them. And so we have quality of life trials as well. And a lot of times we combine those two. Those are the two most important parts of clinical trials for me, are the combination of treatment. Is the therapy going to work to keep the cancer from growing? And does it impact or improve or make a dent in quality of life? Most trials currently are based on pathology, meaning that the tumor has to be a specific type of cell. In brain tumors, it's a lot of the trials are focused on glioblastoma. We have meningioma trials, but that is determined by the pathology, right? So Dr. Sivakumar goes in, gets the tissue out. We have a suspicion of what it is, but then we look at it with our neuropathologist and determine what specifically it is. And so that's the pathology part of it. And then it depends on whether it's primary or recurrent as well, meaning is this new tumor that was just found and what therapies may benefit in that setting? Is this recurrence, meaning it's been through some therapies and has continued to grow? And so we have trials looking at why therapies fail and what best happens if you're treated with something first. What's the next best thing to do after that? And then a big part of where we're headed and where we are on the cusp of is molecular targets. Molecular targets are looking at the genetics or the inherent characteristics of the tumor itself, more than just the pathology, means what's the DNA of it. Typically, we think of cancer as a tissue that has some kind of genetic change, meaning a normal cell divides once and then stops because it's happy. A cancer cell divides and divides and divides and doesn't stop because it's never happy. And then that causes you to have symptoms. If it's in the brain, it causes neurologic symptoms. If it's in the body, it can cause other symptoms. And so those changes that occur from a normal cell to a cancer cell occur predominantly at the DNA or molecular level. And so we're learning now that there are specific changes that are required, and we're developing new therapies for those changes. So if we're looking at a clinical trial, we start typically with a phase 1 study. A phase 1 study is a safety evaluation. We have a new therapy and we want to treat people with this therapy. The first thing we want to see is it safe to give to people? To get to a phase 1, obviously it goes through the lab, it goes through animal testing many times. And then we have to figure out, is there a dose that we can give that's safely given to people, or does it cause so much toxicity or side effects that no one can tolerate it? And so a phase 1 study looks specifically at that. What's not typically answered in a phase 1 study is, does it work? That's not what a phase 1 study is typically aimed at. Obviously, we're picking therapies that we want to see work in brain tumors. So there is an inherent selection of therapies that we think will work. But the first and foremost is we want to prove that that we're safe in doing this. So safety is always the first step. The second step is phase 2. Phase 2 looks at efficacy. Does this do what it's going to say? If I think that this drug or therapy is going to treat meningioma cells, does it actually get to the meningioma cells? Does it target the meningioma cells, or does it spread everywhere and doesn't really go anywhere specifically? Phase 2 studies are bigger. They require more patients, and sometimes they can be have a control arm, meaning one patient gets the therapy and another patient doesn't get a therapy, and that's called the placebo arm. Many phase 2s don't have that, but sometimes they do. And the reason for that is we want to prove that this therapy does what it says it's going to do. Obviously, as we move from phase 1 to phase 2, we continue to monitor for safety as well. But this is where we start looking at some of the more important aspects for patients is survival and disease control. Does this change how long people with a diagnosis of a certain cancer live? Or does it change how we're able to control the disease so that patients have a higher quality of life for a longer period of time? That's where disease control is, that this cancer is there and it's been causing some problems. Can we stop that, stop it from causing any more problems, and give you more time to enjoy? And then there's phase 3 studies. Phase 3s are the big studies. These are looking at comparing the new therapy that's past phase 1 and 2 compared to a group that doesn't get it or gets a different therapy. So these are almost always randomized studies. Randomized meaning without you knowing, and many times without the provider, such as myself, knowing. Patients are separated into 2 groups. One group gets the investigational therapy and the other group doesn't. And then we compare the 2 without a bias to see if what we're doing works to improve outcomes. And we can define those outcomes as typically survival or disease control. In order to do this, these are very large studies requiring oftentimes hundreds of patients. And so we collaborate with a lot of our other centers to do this. And within the Providence network, we have several hospitals as well. And so we collaborate within the Providence network so that patients can be included on these large studies as well. So phase 1, 2, and 3 is typically how studies are developed. And it takes a while. In order to get through a phase 1, 2, and 3, it takes years to do that. Phase 1 study, typically a year to 2 years. Phase 2 study, about 2 years. And phase 3 study can take 3 to 5 years. And that doesn't even include the time to get that drug to the point where we think it's going to have some efficacy. So there's a lot of compounds that we study in the lab every so often, and we see one that shows some kind of benefit, and that goes on to preclinical studies. And then from there goes to clinical studies where we're testing it in some other setting, and then regulatory approval so that we can go into phase 1. Well, oftentimes that takes over 12 years. Obviously, we want to try to expedite this, but we're working on developing new paradigms that allow us to move drugs forward with this kind of development. Now that we have the background of clinical trials, what are the new trends that we're looking at in fighting brain tumors? I think there's really 3 or 4 that we're really hopeful about. Immunotherapy is very promising genetic therapy where we're changing the genetics, blood-brain barrier disruption, and then targeted therapy. So what does all that mean? Genetic modification or genetic therapy. This is where we know that there is changes in the tumor cells from a normal cell for it to become a cancer cell. Can we reverse that change or introduce a new gene into the cancer cells or into the body that allows us to target the cancer? Obviously, this is wrought with many ethical and logistic complications as well. Anytime you're introducing a new gene into anything, there can be changes that we can't anticipate. And so many of these studies are still in phase 1, meaning we're still looking to see if they're safe to do. We've had the TOCA 511, which introduced a gene into the tumor cells that once you give a benign substance, the gene converts it into a toxic chemical. And so if that gene is in the cancer cells, it kills those cancer cells. And then more recently in the news was this polio gene, where the polio gene was introduced into tumor cells so that another benign therapy could be given and kill those cells as well. The studies are still early. They're still phase 1, so we haven't moved past into phase 2 yet for genetic modification. What we have is in blood-brain barrier. So the blood-brain barrier is kind of a protective cover to the brain, and it keeps things out. We don't want things, the body knows that you don't want things getting into the brain that shouldn't be there. And so some of the things that we're doing are implanting chemo, and that was FDA approved with this Gliadel wafer that allows the chemo to be given directly into the tumor site. There's vascular therapies also, meaning we change the blood vessels slightly so that chemo can get in. That makes us a hole per se in the blood-brain barrier. And then there's convection enhanced delivery, where we're using our surgical colleagues to slowly administer drug directly into the brain as well. And then the hot topic now is immunotherapy. Again, this probably became more popular with the COVID vaccination studies, but the use of the immune system is probably our strongest ally in fighting any disease. The human body is developed to be able to fight disease on its own. What happens with cancer, though, is that the body doesn't recognize the cancer as something it needs to fight. It doesn't recognize it as foreign. So what we're looking at is developing new therapies that get the immune system to recognize the cancer as foreign and then allowing the immune system to target it. This has shown tremendous promise in many other cancer types, from lung cancer to melanoma, where it has really changed the focus of how patients are treated. We're still working on developing a new therapy in brain tumors that can harvest this immune response to fight cancer. And we have a clinical trial looking at 2 very strong immune therapy agents to rev up the immune system, specifically for glioblastoma as well. But what I think is going to change and where the future lies is in tissue, in molecular profiling. Molecular profiling, again, is getting the DNA and characterizing it so that we know what the targets are and how we can best choose agents based on that. Currently, what we're doing is getting the tissue, thanks to Dr. Sivakumar, and then looking at all of the DNA of the entire cell. You may have heard a long time ago about the Human Genome Project. That project was a tremendous advance in our ability to characterize DNA. What's happened since then, where we are now, is that it doesn't take years to do the Human Genome Project anymore. It takes hours to days. We can characterize the entire cell DNA and have answers within a few weeks. Meaning, if we get a tumor cell, we know what mutations occurred from what is a typical normal cell, for example, in a glioma. And we can get this kind of answers, that there are these mutations, that these are mutations that are typically seen or not seen. And then we can pick agents that would potentially target this. This is just a snippet, but we can do the whole genome. We could do all the cell, all the DNA of the cell. And that's where we are now. We are doing this on every patient. We are getting this information. And what we're doing is using this information to develop those clinical trials so that we can target, for example, BRAF in this setting for individuals that have that mutation, or IDH1 for individuals that have that mutation. And that's where our clinical trials are now. But the future looks even brighter. So in order to do this now, we need Dr. Sivakumar to go in and remove it. So remove the mass, remove the tissue so that we can get the tissue and then characterize it. But what's the future? The future is that we won't need the tissue, that we will be able to collect spinal fluid. The spinal fluid is the normal insulation around the brain. We'll be able to collect that, and we will be able to characterize the DNA from cancer cells as they shed into the spinal fluid. What is the same genetic profile? We'll be able to understand that there are mutations that occur in tumor cells without having to go in through a brain surgery. We are beginning to explore this on certain cancer types already. We can either characterize this by circulating tumor cells, CTCs, or circulating tumor DNA. And the way we do this is by collecting the spinal fluid. In lung cancer, it's shown to be very effective. In other cancers, we're still working on that. But I think this is where we're headed. But obviously, getting spinal fluid still requires a procedure. That procedure is typically a lumbar puncture or a spinal tap or a surgery still. So how do we improve on that? Obviously, the next step is getting this information from blood samples. Many patients get blood tests for many reasons. And so what we can do is get a blood sample and figure out if there's cancer circulating DNA or cancer tumor cells in those blood samples, collect that, and then characterize the genome of those tumor cells or that tumor DNA. And we already have a numerous number of genes that we're able to do this for. For brain tumors, I think this is the next step forward, that we're going to use blood samples to make diagnoses and make treatment plans. Obviously, this takes those clinical trials, that research that goes into it to get there. But I think we're on the cusp of that. We are already collecting blood samples and doing the tumor analysis on cells that we collect already. And then what does all this mean? Targeted therapy. We get this information, we see these mutations, and we pick therapies based on that. The Nobel Prize was won for this type of therapy not too long ago with the discovery of this BCR-ABL mutation that was in leukemia cells. Once we discovered that, the reason it won the Nobel Prize is we've essentially cured that disease. For gliomas and brain tumors, we haven't discovered that specific gene. We think that there's many genes that are probably involved from this list, but what we're doing and how we're going to move forward is we're not going to treat everyone the same anymore. We're going to say that if you have a certain mutation, you get this green therapy. If you have a different mutation, you get the orange therapy. If you don't have any of these mutations, then maybe go forward with the traditional therapy in blue here. And that's how we want to be able to understand tumors and develop therapies to help individuals. So obviously there's barriers to this. The clinical trials help us get through those barriers, but each of these barriers serves as a potential target, a potential way to overcome cancer of the brain. And I think, again, these clinical trials are a vital part of that. Thank you, everyone. I think we're going to have Treasure come back on, and then we'll be able to answer some of your questions.
Thank you. Thank you so much, Dr. Wagle. Actually, that was such an informative presentation. And I think it's really hard for the public to understand what is involved in clinical research. It seems to be somewhat aloof. We all hear about research. We know that it's there, but what kind of research there is, what's involved, and what goes on in research, that's really tricky. So thank you for sharing that with everyone. Before we begin our Q&A, we have a few questions for you. If you could please answer the poll that you see appear on the screen and give us your honest feedback, we would greatly appreciate it.
While you guys notice that, I want you to keep in mind how my partner, Dr. Wagle, how happy he was when he talked about how brain surgery was not going to be necessary and putting me out of work. It's okay. It's for the best.
Are there any other, and please feel free to go ahead, and I'm going to open it up for Q&A. So if you have any questions, please go ahead and look at the bottom of your screen. There should be a Q&A box, and you can type in your question there. Thanks again for taking the time to fill out this poll. So I do have a question in the Q&A box. And it says, where can I find out about clinical trials, Dr. Sivakumar and Dr. Wagle? Where are they offered?
While Dr. Wagle answers, I'm going to put the link in the...
There are several ways. Obviously, when you're at a brain tumor center such as ourselves, meeting with the neuro-oncologist, will help you select a trial that fits with what they think will help you the most. And so it's really a partnership between you and your treating doctors to help you find those trials. A resource that I suggest to patients is clinicaltrials.gov. It's a website that's run by the FDA that lists all clinical trials, regardless of location or tumor type. It can be daunting. It's a little clunky to navigate. And so it is a search tool. And then obviously we have our clinical trials and we have our website that can help you get to those questions as well. But I do think, given where we are with clinical trials, talking to your doctor, seeing what's available for you here or anywhere else is the most important first step.
Another question that we have in the Q&A is, how does tumor painting work? Does a patient drink a contrast prior to surgery?
Yeah, that's a great question. There's multiple different types. The type that we use here at the Pacific Neuroscience Institute and in Providence is a system. Just a little bit of background. Providence is a 60 hospital system that travels from Alaska all the way down to Texas. And it's the third largest not-for-profit hospital system in the country. Why that's important when we're talking about these higher level concepts like comprehensive brain tumor care, we don't just have the resources of the Pacific Neuroscience Institute. We have all of the providers across that 60 hospital system. So we make decisions on a system level. And one of those was this tumor painting dye situation. There's multiple different ones that are out there on the market. And a few of them have received a lot of press in the media related to recent Food and Drug Administration approvals. However, the ones that we use as a system right now is intravenous fluorescein, compared to other ones that are on the market that are actually quite expensive and require patients to take the medication a day or two before surgery, potentially even having to stay in the hospital the day before surgery, having light sensitivity associated with it prior to the administration of the surgery. We give intravenous fluorescein, which is a commonly used medication throughout the hospital. And we give it 45 minutes intravenously before we need to see it. And it gets taken up by the abnormal cells that have issues related to the blood-brain barrier that Dr. Wagle was talking about. We have special, very high technology microscopes that have different filters that can look at these different reagents. So we have a fluorescein filter that I can turn on and switch back and forth between white light like you saw on those videos. And I can go back to seeing the normal microscopic view versus this fluorescein view and guide my tumor resection. Incredibly interesting technology.
Sounds like it. It's so interesting how the dye knows where to go. Another question from Linda says, what are the 2 immunotherapies you are recommending?
Well, immunotherapy is still currently investigational. So we have a clinical trial investigating the use of nivolumab and Yervoy in the treatment of brain tumors. But immunotherapy in general, I think, is still something that is done within a clinical trial. We have certain mutational patterns that we see in individuals that will potentially respond better. And so those are the individuals that we try to get on those studies as well. The immunotherapy trials that we have open are currently for glioblastoma, which is one of the more common but aggressive types of cancer. And so we have that study open through one of our centers within Providence.
Is there a connection between brain cancers and strokes? Is another question.
Yeah, that's a great question and a pretty complicated one at that. There are certain tumors that have a higher risk of hemorrhage, and certain metastatic tumors have a higher tendency to bleed. And just to back it up a little bit, when we're talking about a stroke, we're talking about any interruption of blood flow to the brain, and that can either be a clot or a hemorrhage or a bleed. So that's what we mean when we're talking about a stroke, and tumors can be related in both ways. For example, glioblastomas and primary brain tumors can cause more clotting inside the body, and that includes increasing your risk of stroke because they're releasing a lot of different tissue factors that can cause these clots that can go up to your brain to cause a stroke. Additionally, a lot of these tumors, like I talked about, have these leaky blood vessels that don't behave the way normal blood vessels do. When that's the case, there's a higher risk for bleeding. And so oftentimes we get patients who present as the first presentation for their tumors as a brain bleed. And then we do additional workup and see that it's not just bleeding in the brain, it's an actual brain tumor.
That's really helpful. Thank you, Dr. Sivakumar. Another question from Nora Devine is, does the oncologist help the patient to get the services of a team to treat the patient? It takes a village concept.
Certainly it does. It certainly takes a village. And so it's always a collaboration, not just for making the diagnosis with the neurosurgeon, with the neuropathologist, with the oncologist, but getting the care that you need between physical therapy, rehab, palliative therapy. The goal of the oncologist is to get you the resources you need to be able to manage those kinds of complications of the cancer as well. We have a tremendous physical therapy group that we work with, that we have many of our patients go to as well. Little Company Mary has a tremendous palliative care program as well. The neuropathologists are tremendous. And so it takes, going back to that Dr. Sivakumar's message, it does take a village. It takes a village to get the right therapy, and it takes a village to get the right resources for you as well.
One of the things I'd like to add to that, if I may, is our pharmacy group here at the hospital are incredible, and they work as an advanced level pharmacy, and that matters a lot when it comes to Dr. Wagley's medications. I should probably let you answer that because you deal with that on a daily basis.
Yes. So one of the limiting factors for many patients is the costs of the chemotherapies or the targeted therapies or any therapy. And the insurance companies are hard to deal with. They're hard for you to deal with. They're hard for me to deal with. And they do not make it easy. So we have a tremendous pharmacy program that works with you to kind of push the insurance company to the right outcome. That they call, they do a lot of the authorizations that are required, submit a lot of the paperwork that goes on behind the scenes to get you the therapies that I think you should be getting. Not always, but more so than if you were doing this on your own.
Great. I'm glad you called out the pharmacy. I was sitting with Gloria the other day, one of our pharmacists, and she takes such an immense amount of time to talk to patients and go through what they need. And so I'm super happy to hear that. Another question from Molly is, what type of tumor is a Jumenjio paracytoma?
Yeah, that's an interesting one because it's not a straightforward answer to it. Oftentimes, it looks like an aggressive type of a meningioma. And as we talked about, meningiomas are one of the more common primary brain tumors that originate from what are called the arachnoid cap cells or the dura, the covering of the brain and the spinal cord. Hemangiopericytomas arise from the same location, but they're considered more of a soft tissue sarcoma that come from that same area. And they're typically more associated, instead of with those cap cells, with the vessels within the walls, or the cells within the walls of the blood vessels themselves, or the capillaries, and that's where they tend to come from. Because they have more of a blood vessel origin, they tend to be more aggressive, have more swelling and edema associated with it.
Doesn't sound like a fun tumor. Here's another question from Nora. In a brain surgery, is there memory loss?
We try to minimize that. It's a very good question. And it really depends, as we talked about, a lot on where the tumor is localized. Memory actually incorporates the majority of the brain. So the circuits that to date we still don't fully understand go into the frontal lobe, go into the temporal lobe, involve the parietal lobe, and when we're talking about visual related issues, involve the occipital lobe too. A lot of what we try to do in terms of minimizing that collateral damage is having an understanding before we go into the operating room of what the brain itself in that individual patient, because every patient has a little bit of difference within their brain, where the specific things related to that patient are before we go in. And when it comes to memory and things like that, sometimes we do what's called a wake surgery for brain tumor resection, where we're actively testing the patient throughout the course of surgery while we're removing that tumor.
Okay, this is going to be our last question, and there's a lot of comments thanking both of you for your time and making this so understandable. The question is, are there any research results connecting genetics to brain cancer, or is it more of the result of nurture?
Well, that's a great question, a loaded question, really. Well, what we're learning is that there are certain genetic changes that do lead to cancer formation. These are typically seen more commonly in individuals that have a family that has cancers, but we are being able to characterize those. The majority of brain tumors, though, don't have a familial disposition, meaning they don't have a genetic pattern that is present in the whole body, that is spread from one generation to the next. What we're seeing is that the mutations that occur in a couple of cells only within the brain or within the body, and that leads to that group of cells growing uncontrollably and becoming the cancer. So it's not the whole body that's affected. It's not the whole family that's affected. It's just a couple of cells. But those couple of cells are so bad that they become cancer. And so we need to figure out what are the changes that occur that lead them to become cancer, and then target those changes.
Thank you all for taking the time to listen. We had some really great questions. Thank you all for taking the time to listen and even ask these questions, because they were really great questions that I even was thinking of too. And a big thank you to Dr. Sivakumar and Dr. Wagle for taking the time to provide us with such valuable information and make it super understandable. We will be sending a recording of this presentation to all attendees for you to have. We will also be posting this on our Facebook page for anyone, for everyone to be available to view and share. You can find us at Little Company of Mary South Bay on Facebook, all one word. For any additional information or to schedule a physician appointment, please call our Patient Engagement Center, and it's 1-888-HEALING. Thank you all again, and have a great rest of your evening.
Thank you.